Perspective slideshow. This assignment for DNP 700 Healthcare Policy, Organization and Delivery was produced by Don Cleland and I, Mike Kelly. The story relates to a personal experience of a friend of ours who was admitted to the hospital for 7 days. The experience led to issues of mistrust for the United States healthcare system. So this is a single 43-year-old Vietnamese female with advanced education who is obtaining her DNP currently. This individual became acutely ill, experiencing shortness of breath and fever. The illness forced her to go to the emergency room due to the severity of illness and symptoms. She was admitted to the hospital with a tentative diagnosis of pneumonia. Her length of stay was 7 days on the medical surgical unit. Over this time, she had received daily blood cultures, bronchoscopy, chest x-rays ×4, angiogram ×1, and intravenous antibiotics daily. After a 7-day stay, this individual was discharged from the hospital. Within 7 days of being discharged, she had received an invoice for unpaid medical bills by her PPO insurance. The unpaid portion totaled almost $11,000. The PPO had refused to pay for most of the lab work, diagnostic tests, and specialty physician consultations. The relevant domain is trust versus mistrust. The experiences leading to trust versus mistrust. Prior to her admission, our patient had no reason to mistrust the healthcare system. Following treatment, mistrust for the U.S. healthcare system developed. The individual felt the insurance carrier communication was poor and misleading. During treatment, the diagnosis was delayed due to medical errors, leading to misdiagnosis and increased length of stay. The individual was charged for multiple diagnostic exams that took place after the failure to obtain a nasal swab. There was some question of the illness, if this illness was work-related and should be covered by work compensation and state stability. This individual developed distrust of the United States healthcare system, physicians, insurance coverage, workers' compensation, and ancillary government assistance program. According to Caputo, 2013, highly educated professionals often have a deep lack of confidence with medical providers. Distrust of medical providers by the general American population is 35%. Strong barriers exist between the Vietnamese culture and healthcare. Frequently, they do not want to focus on the illness, but instead believe that lack of improvement results in symptoms worsening and the reduction of psychological well-being. This individual trusted the healthcare system prior to her admission. One way for providers to manage mistrust is to develop open channels of communication and empower patients to speak up about issues affecting their trust. The discussion. Before admission, this individual had never been hospitalized. According to the chart review, a nasal swab was not carried out until 3 days after being ordered. According to McDonald's et al. 2013, it indicates that 61% of hospitalized individuals experience delayed diagnosis due to delayed diagnostic procedures. The individual experienced an array of diagnostic procedures, a broad-spectrum antibiotic and broad-spectrum antibiotics until the physician discovered the absence of the nasal swab results. It was discovered that the nursing error occurred, the diagnostic procedure was not carried out, and a delay in treatment extended the length of stay. Further, this patient was unaware that over 70% of diagnostic procedures and both specialty consultations from pulmonary and infectious disease were not covered by insurance. According to, for the Record Valley Publishing Company, 2012, over 30% of Americans experience a medical mistake. In addition, 20% reported being misdiagnosed and 45% received unexplained and or incorrect bills. Further, 35% of professional healthcare staff blame miscommunication and fatigue as the primary reason for misdiagnostic procedures. Physician transcribing errors contributed to misdiagnostic procedures and have increased hospital length of stays greater to or equal to 13 days. More discussion. Physician specialists were not covered and were unnecessary had the nasal swab been performed. The patient $700 out-of-pocket for 2 CAT scans during her inpatient stay. The patient returned for a third CT 1 month later for follow-up. The individual is expected to compensate for over 7% of the bill accrued by expensive diagnostic procedures and unnecessary specialty consults as a result of a medical error. According to Schwartz et al. 2013, researching 399 cases revealed approximately $174,000 of unnecessary costs due to delays in treatments. She felt that better communication about charges being incurred needed to be more forthright and proactive. So, just to recap on the mistrust, this individual was responsible for 7% of $10,008. That comes to a total almost $11,000 of a hospital bill. The total bill was $144,762, and just for the pneumovirus. Multiple unnecessary diagnostic procedures had taken place, and a multitude of unnecessary charges were accrued. Potential solutions. According to Noam Metzer 2006, a patient-centered approach should be used with healthcare, seeing the patient's experience through their eyes. Potential solutions at a hospital level may reduce future occurrences. According to McGlynn, McDonald, and Castle 2015, institutions' education committees must strengthen clinical reasoning, teamwork, communication, and appropriate procedural application to promote diagnostic competency. Further, developing diagnostic competency improves the quality of care while reducing the length of stay. Successful interventions aimed at reducing diagnostic errors and reducing length of stays include structured staff education and technique competency. Further, the implementation of technology-based diagnostic feature loops have been proficient in detecting diagnostic error. Continued potential solutions. Potential solutions aim to resolve the costly issue begin with calling the radiologist's office responsible for the CT scan. After assuring the company was paid cash, the company dissolved charges. Specialty physicians were then contacted for consultation expenditures and refused to reduce their costs. Next, 3 separate lawyers were contacted and refused to pursue because, quote, there is no case when the patient is better, unquote. According to McDonald 2013, up to 59% of malpractice claims are attributable to diagnostic error. Further, the leverage for similar malpractice cases due to delayed diagnosis leads to inappropriate care, poor outcomes, and increased costs. Workers' compensation and state disability was then contacted for support since the individual felt that pneumovirus was contracted at the workplace. According to Kilgore, Cosby, McKenzie, and Colley, 2015, research identified that the majority of interactions with workers' compensation were negative and contributed to further psychosocial stress. Finally, after numerous consultations and an appeal, state disability agreed to pay a portion of the costs. However, refused to pay the first 7 days. State disability finally agreed to pay the cost only after an appointed physician had to review the case and an appeal letter was completed. To facilitate recouping costs, this individual had to take time off work and school. The individual does not qualify for Medi-Cal and must depend upon collateral support services and her own ability to pay for services. This concludes. Thank you for watching.